So here we have our first case. A 45-year-old woman comes to the clinic with complaints of muscle weakness. Her symptoms began 8 weeks ago and are worse at the shoulder joint. The weakness has been increasing progressively and she is now finding it increasingly difficult to walk up a flight of stairs or even comb her hair. No history of trauma. Past medical history is insignificant and the patient is not on any medication. A muscle biopsy is performed which reveals MHC class I overexpression on the sarcolemma with CD8+ lymphocyte infiltration. What is the most likely cause of the patient's condition? Any guesses? Okay, so this is a classic case of polymyositis. Let's find out why. Polymyositis is thought to be a disease or viral or autoimmune etiology typically seen in a middle-aged female. The patient starts developing proximal muscle weakness, especially in her shoulders. Pain may or may not be present, and keep in mind that this disease shows no typical skin findings. Now coming to the pathological features of the disease. Muscle biopsy of a patient suffering from polymyositis shows endomesial mononuclear infiltrate with patchy necrosis, regeneration, and fibrosis of muscle fibers. There is also increased expression of MHC class I antigens that are presented to CD8+ T lymphocytes. The lab findings show elevated levels of creatine kinase and aldolase. Autoantibodies like anti-nuclear antibody and anti-Jo1 antibodies can also be seen. Some complications of polymyositis includes interstitial lung disease and myocarditis. Now let us see the second case. A 45-year-old woman comes to the clinic with complaints of muscle weakness. Her symptoms began 8 weeks ago and are worse at the shoulder joint. The weakness has been increasing progressively and she is now finding it increasingly difficult to walk up a flight of stairs or even comb her hair. No history of trauma. She has a lilac periorbital rash, a sunburn on her cheeks and discrete red areas on her knuckles. Past medical history is insignificant and the patient is not on any medication. A muscle biopsy is performed which reveals paramyosial inflammation with CD4+ infiltration. What is the most likely cause of the patient's condition? As you can see, this case is extremely similar to the previous one but with some minor differences. So what is the answer? Okay, this is an open and shut case of dermatomyositis. Let us find out why. Dermatomyositis is very similar in presentation to polymyositis. It is also seen in middle-aged women with symmetric, proximal muscle weakness, with or without pain. However, in addition to this, we see characteristic skin changes like a malar rash, Gautran papules, and heliotr rash. On muscle biopsy, we find paramyosial inflammation in contrast to the endomesial inflammation seen in polymyositis, and there is a CD4+ T cell infiltrate instead of CD8+. So I have some slides here showing the skin findings. These are the Gautran's papules. Here you can see the shawl rash on the neck. And in this image here you can see the heliotrope rash. Okay, so now that we have seen both the cases, let's try to summarize the main differences between these diseases. In polymyositis, the skin is usually spared while skin involvement is present in dermatomyositis. The endomysium is affected in polymyositis while the perimysium is affected in dermatomyositis. There is CD8+ infiltration in polymyositis while dermatomyositis shows CD4+ infiltration. With this, we end our first video in rheumatology. Thank you so much for watching.